prove to me or demonstrate to me that all this effort and all this virtual care actually is going to really change outcomes. It's not just kind of busy business that's really not going to change fundamental outcomes. So I think there's a definite evidence gap.
Welcome to Series 3 of the Future Health Podcast, a podcast on the way we work, the work we do, and how technology will influence the future of work in New South Wales Health and the healthcare industry. We have an incredible lineup of guests this series, and we look forward to sharing it with you soon. Feel free to like, share, and subscribe so you don't miss a thing. Hi everyone, welcome to the Future Health Podcast. My guest today is Professor Tim Shaw, who is a Professor of Digital Health from the University of Sydney. He's got many passions, including cutting-edge models of care, as well as data and new technologies. So thank you so much for joining us today, Tim. I'm really looking forward to speaking to you. Would you be happy to introduce yourself a little bit further to our audience and give us a bit of background?
Sure, so Richard, it's a pleasure to be here, and thanks for listening. So I'm a Professor of Digital Health at the University of Sydney. I was the inaugural Professor of Digital Health at the university. I have a wide range of interests in digital health across, as you were mentioning, kind of new models of care, how we apply those, and then also how we use data to its best benefit within the health system. I also have quite a strong brief within my role and external to my role around how we build capability and capacity in workforce around digital health and what does that mean. And I'm also an academic lead within the Digital Health Cooperative Research Centre, which is a $110 million digital health grant that was funded 3 years ago. So I've had a kind of a bird's eye view of digital innovation across the country over the last 3 years as well.
So Tim, thanks for that intro. That was really interesting. And let's dive straight into it because you mentioned your passion about, digital health and models of care. So let's dive into what are the current models of care that we're really struggling with, and what should the models of care when it comes to digital health be for the future so that we can be best prepared for what's coming?
So thanks, Teresa. So when I'm considering new models of care and the impact of technologies, I think it's worth considering a few aspects of how technologies are actually interfacing with healthcare at the moment. I actually think that healthcare is actually really high tech, but incredibly low digital. So what I mean by that is we can do incredibly intensive high-end procedures, but we have trouble with some of the fundamental basics of digital health. I myself have congenital heart disease and atrial fibrillation, so I've had a lot of interfaces with healthcare. And in my own example, I see a cardiologist once a year. We have a very good relationship, but I have no interaction with her between visits. There's very little communication between my care team, no transfer of information, no gathering of personalized data around the care that I receive. But then I can have these incredibly high-tech procedures like a cardiac ablation where you're kind of wheeled into feels like the Starship Enterprise to have that procedure, but then that information can't be shared readily with the team. So I think there's a couple of layers I look at with new models. So one of them, I think, is that we're not using technology to wrap around that kind of consumer experience. So we're not really understanding how different technologies can close those gaps between your care events, how you can use simple things like interactive voice response systems or SMS prompts, all the things that we use in other aspects of our life digitally to wrap that kind of high touch digital piece around the way that we interface and have care delivered to us. So there's a more continuity of care around that. I think the second thing for me with new models of care is actually around how we personalize those models of care. So how we actually understand information flows and data behind each of us so that we get a personalized model of care. So for me, my data should be tracked between visits and my care should be titrated between those visits based on the type of activity that my heart's undergoing or weight I might have gained or other factors in my life. So to kind of really personalize those models of care so you get a much more continuous aspect of care delivery.
Right, yes. And it's interesting you talk about sort of disconnect there, like say for your example there where, you said you see a cardiologist once a year and in between visits there's no interaction. Do you think that, and, going back to your Do you think that's a legacy of when old systems didn't connect? So you've got, your sort of acute medicine versus your GP, and the systems are completely different. Do you think how much of a role do outdated systems have in this disconnect?
There's no doubt, right, that we've got some failures in interoperability and technical interoperability and all those types of things. But I actually think that's the easy part on some level. I think it's much more of a technical-social problem that we have. And I sometimes reflect that we're actually, a lot of what we've been doing at the moment is digitizing 19th century healthcare. So we're kind of using digital technologies and seeing how it can support into what we've got and focusing around that, rather than actually how we can use technologies to transform care. So I definitely agree that fundamentally we've got to sort some things out. So we've got to sort out how we link primary and acute care, both data and care models. So there's easy flow of information in real time between those different domains of care. Obviously, we need interoperability standards where that data can transfer and all those types of things. But layered over that, even with those systems in place, is actually a change management process of then how you start to use these technologies to disrupt our traditional models of care, to actually change the way that we deliver that. And a lot of that, for me, is putting the consumer in the driver's seat around that and changing some of the emphasis. So it's away from the clinician managing all the care to actually a shared care model and much more exchange of information and understanding as we move forward.
So what do you think some of the challenges are in adopting new ways of doing things, and putting aside sort of the disconnect between, primary care and acute care, even within a hospital, for example, where you've got procedures happening here, but then you're getting care in another department and possibly there's no connection there. What do you think some of the challenges are in being able to have a smooth transition and adopting change better?
So I think there's quite a number of challenges. As I said before, I think obviously there's technical challenges. I think a lot of it is there's obviously funding model challenges that we're not funded to deliver new models of care as well. So most of the way that healthcare is funded is not to attempt to deliver care in new ways, but to continue to deliver care like we do. So I think obviously if you started to move towards more consumer-centric preventive models of care, then you have to look at kind of funding models around capitation and others where people are actually paid to help keep people well and keep them out of hospital, because I think that pushes you down that route of actually continuous monitoring, personalization and so on. So I think funding certainly a problem. I think there's a culture in healthcare of conservatism and not necessarily changing, and that's a good thing. So we don't want healthcare to radically change constantly, but I think there's a conservatism to actually changing the way we deliver care. There's very strong existing models that have a certain kind of model attached to it, with the doctor being in charge of the care model and delivering that in a certain way. So I think there's a lot of change management required to actually shift that. And I think some new models may actually reflect on, maybe it's not the doctor in charge, maybe you have a virtual navigator that then calls in clinicians and different teams as you needed to care for that person. So totally different ways of reflecting on that. So I think we need to understand how we can change that model and the mix of clinicians and the type of practitioners that deliver that care. And that's not an easy thing to do in healthcare.
Yeah, and I mean, I think, going back to your point there about changing the model of care, in health, a lot of what we aim for is about, evidence-based, but we don't necessarily evaluate the things we do. And, to your other interest there around data, there's obviously a lot of data to be gained under those models of care and, patient outcomes and things. So what do you think we could do to evaluate better, the way care is delivered and what patient outcomes are? And would that better inform change?
Yeah, no, I think this is a key point you raised. So we don't yet know in digital health really what works well, what the outcomes are. And I've had many conversations with senior leaders in healthcare who say, prove to me or demonstrate to me that all this effort and all this virtual care actually is going to really change outcomes. It's not just kind of busy business that's really not going to change fundamental outcomes. So I think there's a definite evidence gap around that delivery. And we need to start gathering information and data around that. We need to have many more, much more implementation studies of virtual care. I've heard people joke that there's more pilots than Qantas in virtual care in Australia, that we're doing lots and lots of pilots, but it's actually really, there's very few demonstrations of actual impact where we've taken a new model of care, applied it, whether it's a out of hospital model of care or out of home community-based care models, and actually demonstrated real impact from the impact of digital on that model. So I think we need to gather more evidence around that. And then obviously that whole data section underneath that is crucial. We should be able to gather that information flow and data to understand those new models of care and what their impact has been.
So from your experience or, any research that you've come across, possibly from other jurisdictions, are there any places that do it well that we can look to? Obviously noting that we'd have to adapt it for our jurisdiction and our, population needs. But are there any examples you have of areas that do it well?
Look, I think to really look where it's being done well, I think you would probably have to look offshore, to be honest, at the moment, in terms of where some of the key examples are. And I do look to some examples in the US, although I don't often look to the United States for great examples of kind of care. But particularly within some of the health managed organizations, or HMO as they're called in the US, particularly groups like Kaiser Permanente, where really they've started to unpack that, and Kaiser is really a cooperative health delivery service. So HMOs manage your care holistically based around employers. So they're very large in California, and because they're funded a fixed amount of money per patient effectively, they've really started to introduce new models where they can holistically manage a person. So they have combined data sets. So they have the primary and acute care data sets combined, and they can monitor that, and they do continually call people up. So if you forget something, you don't go for a lab, you don't do a test, your data starts to reflect that you're not doing so well, they actually start to outreach to you and have that kind of conversation with you and start to wrap that technology around you. So they do a kind of end-to-end digital wrap around the patient to manage that. So I think there's some good examples of that. In the United States as well, in Boston, I've worked with groups. There's a group, cardiology group in Brigham. Callum McRae runs that, and they've been really looking at how you manage cardiovascular care. And I was really intrigued by this when I was there, because I spent quite a lot of time with some virtual navigators that work for Callum, and what they've done in cardiovascular care and metabolic disease management in Brigham is they've got combined data sets of primary and acute care data, and they employ grad students, often psych grad students. They give them 3 months training, and then they turn them into virtual navigators. So they actually look for patients through their data that might be not compliant with medications around blood pressure management or glucose monitoring. They invite them into a program. They're given a virtual navigator that communicates with them as a real person, but they do it virtually. They have smart AI in the back end looking at the information, and they basically bring those patients within that organization up to compliance with medication and health regimes around exercise and fitness and so on, and then hand them back to their general practitioner or their care team after they've been brought on. So, and what they found in that study was that they greatly reduced the reliance on high-cost cardiovascular care services and actually had better patient outcomes. So obviously those virtual navigators worked underneath underneath the care team, but that care team only dealt with the people that actually needed to be dealt with. So I think those kind of models where you're starting to break that open a bit, so you're starting to say, okay, what's the best person to manage your care or my care? When do you actually get a flag where you need to be managed more intensely? Who should do that? How can we reconstruct those roles in healthcare?
Yeah, and that's interesting because in that example, there was a few different technologies, because you've got your artificial intelligence there to look through the data. You've got virtual care as a means to interact with people. And then you've got an innovative workforce model if you're using students as virtual navigators. So that's clearly something where you've had to look at multiple things coming together for an effective solution. Is that something that we, could potentially adopt quite easily here in Australia or New South Wales, for example, or is that only possible because their particular funding models allow it? Like, is there limitations on what we can do?
Oh, no. I think we absolutely can. And I'd like to acknowledge, particularly in New South Wales, that there's some really good attempts at this. So Elizabeth Koff herself has been working with collaborative commissioning projects. I know something she's backed heavily. So there's funding around collaborative commissioning across the state where they're asking local health districts and primary health networks to come together to kind of reconceive care of a particular patient population. So there's work going on in Western Sydney around, ironically, because I have atrial fibrillation myself, around AF management. There's work down in Murrumbidgee around, I think it's around COPD and other aspects of care. So there are attempts to do this, because you do need to kind of reimagine it to do that. It's very hard to do that when you're just tinkering. Often I reflect to this point on the horizons of healthcare. I don't know if you're familiar with those, or the horizons of digital implementation into healthcare. And, Horizon 1 is just to get technology, the tech we have to make it work properly. Horizon 2 is to start to apply some smarts like AI and others into it. And then Horizon 3 is actually to use it to transform and develop those new models and totally new approaches. So I think in New South Wales, there's attempts to push into Horizon 3. I suggest that we can see a lot more of that happening over the next 5 years. I think COVID has also opened the door to this and opened the door to government to look at refunding. We know that obviously the Medicare item around telehealth was a start in that direction. So I think it's a really exciting moment. So I think we're going to have those open. But it's you need to have that whole of healthcare look at something to really change that model.
Yeah, I agree. And I mean, it's interesting because you mentioned the horizons and, where we're currently at. But in order to get to Horizon 3 and, continue to maintain it and sustain it, we have to think about our future workforce too. And I know, so you coming from a university and the importance of our student workforce and curriculum being designed so that these sorts of things are considered important as part of the learning versus traditional curriculum. How important do you think that is, and what role can universities play in partnership? Because it's not just about NGOs and primary health networks. It starts right with our students, I suppose, in some ways.
Absolutely, and it's funny. So I was on a call with Monash University last night, a collaboration with Sydney Monash, looking at curriculum development and digital health across our health faculties, and every university is struggling with this at the moment. I think struggling is probably the right word, because nobody's quite sure how much is being delivered, what it's being delivered in, and we're just starting to really look at how we do this. And unfortunately, everybody just thinks digital health is EMR. So everybody electronic medical records, everybody immediately goes, oh, we just got to teach people how to use the EMR. And so there's a lot of that happening, or maybe informatics. And Horizon 3 stuff is much more challenging, because there's not many examples of it out there yet. And we do need to equip the future workforce to be able to kind of do that. So we need to start introducing that. So yeah, we're all actively looking at how we can introduce this type of aspects. Sometimes I actually think allied health and nursing are further ahead in their conceptualization of care in this way. And I think allied health in particular is very active in promoting how you use technology with new models, because a lot of it is about monitoring people and continuity of care in allied health, whereas I think some particularly specialist medical care is still very truncated in the way that we care for patients. So look, it's a really important thing. We're all looking at trying to be creative in that space. There's many curriculums being developed. Sydney collaborated actually with New South Wales Health to develop a capability statement, and key to that was including the horizons to say, look, this is what people need to be safe and effective. You've got to be able to use electronic medical records. You've got to be able to do that kind of stuff. Then we had another area where you need to start to understand how to analyze data, what that means for your practice, what the data feeds that are coming to you. But then the other area was really starting to reflect on, okay, what does it mean for you wrapping or pouring digital technology into your practice? What does it mean to monitor your patients between visits? How might that influence your care? So we're all looking at this and trying to create creative ways to do that. But when the system's not quite there yet, there's always a bit of a lag. Primary care is more advanced in this as well. Often they've had a stronger digital footprint for longer. So I think it's really good to expose our student body to primary care because they're leading the way a lot of the time around the application of digital technologies.
Yeah, and I think interesting point you make there about primary care, because historically acute care has been kind of, you come to emergency, you're in hospital, you get out, and then, next person comes in, whereas that has changed significantly over the years, and primary care has predominantly been about maintaining contact with patients. Do you think we can learn from primary care and what they've done? You mentioned other jurisdictions and offshore, but are there things in our backyard that we could be looking to adopt for an acute setting that have worked in primary care?
Look, I think so. I think rather than learn from, it's kind of embrace, I think is half the problem. I think we have this unusual fracture in Australia that, is really an artifact of our federated system between obviously federal government looking after primary care and states tending to look after acute, that we have this fracture between primary and acute. So I think it is just one care model. So I think that's what I'd say first to that, is that we really need to work on this. And I think still many of our virtual models within acute care are not fully engaging primary care. So I think at a base level, we need to engage primary care in those models. And certainly many of the local health districts are starting to do that, but it's kind of baby steps at the moment in terms of that really shared care model and how do we assess that continuity of care across that. And that's fundamental. So we have to shift our thinking to kind of combining that. Look, I think the way that primary care uses data, I think they're much more efficient at using data. I think the way that you've got PHN starting to aggregate and collect those data sets and start to reflect those data sets back into the team so they can start to understand where they're delivering care in an effective or an inefficient way, or how they can improve that. I think we're just at the beginning of that in acute care services. We really, when I look at a hospital, I see a whole pile of data streaming out of the roof, if you like, going out to report on 4-hour waits or report on bed block or whatever it might be, or report for funding. I don't think we're turning that data around and starting to push that back down to the teams so they can actually use it on the floor to understand the care they deliver and start to use that data to feed into AI models and change care. Whereas I think primary care is ahead in that game. So they're starting to do that. So they're starting to get regular reports from the PHNs. You've got groups like PenCS and Outcome Health that analyze routinely those data sets in the background and provide that back. So I think that's the case, and it fits well with primary care because as patients in primary care, you want a more holistic approach to that, and I think some of that can move into acute care.
Yeah. Do you think one of the challenges though in acute care is that there is much more data? There's more data sets than there would be in primary care, potentially because of the size of our system. Like, not suggesting that primary care is small, but when you've got the number of patients that interact with acute care and the number of settings and the number of data sets that we collect, is it all just a bit hard and a bit too much for our, people just say, oh, it's too much, I can't do this?
Sure, it is challenging. And look, and it's particularly challenging the way that we've organically grown acute care services and the data assets associated with those acute care services, and the ownership of those data assets has largely been related to an organization or a local health district. It wasn't put in as a single system to say, okay, we're putting a single data system in so all these data points fit. So it's nobody's fault that we're where we are. And in fact, New South Wales being ahead of the game in putting in Cerner and other data EMRs has some ways stepped us back slightly, because we went first and put in 7 instances of Cerner, and they don't necessarily talk terribly well together at the moment. Or eHealth New South Wales doing a lot of work around that at the moment, and we're actually looking at a single digital patient record, for instance, now coming into New South Wales, which should be a huge step forward in linking all those different data assets together. But if you look at Queensland, where they put in a single instance of Cerner EMR across all their organisations, so immediately they've just got a single source. So you can sit there and just suddenly see all those data points across the state. I mean, that's very exciting, because they suddenly have that attribute and they can access that. Whereas in New South Wales, we're still really kind of stuck with it at this point, working with each of the local health districts with their own different data sets, and how can we kind of link them together a little better.
Yeah, yeah. Do you think, the interesting point there about, linking data and, how important it's become. With everything that's happened with the pandemic and COVID, there's been obviously a lot more media and public interest in health. Like everyone suddenly is very interested in case numbers, number of deaths, who was vaccinated, who wasn't. And this has been happening for the last, 18 months to nearly 2 years. Do you think that's really driven health to step up its game in terms of being able to accurately report data and make sense of it because they've had to?
Yeah, look, and I think it's a massive opportunity for the system. I think, obviously COVID has been a huge stress and strain on the system and I fully acknowledge that. But, I think we obviously, when you have these kind of shocks to the system, you always look to say, well, what are the upsides of this? And I think there's a few upsides. So obviously one I mentioned before is, opening the door to the whole virtual care piece. But I think opening the door to sharing data and understanding how we can aggregate and share that data for social good, I think is definitely out there. We at the moment, through the Digital Health CRC, are doing a large amount of work with consumer groups actually around what they're expecting. We've just done a very large survey across the country around what consumers' expectations are around their data usage. And I think it's really sharpened all our focus around that as health consumers as well as being involved in the system. And I think there's often a misapprehension that consumers want all their data locked away. But I actually think we've got the opportunity to gain the kind of social license, if you like, to work with consumers to provide the opportunity and the examples of where actually bringing their different data sets can be a major benefit to them. And I think that's what didn't happen necessarily with My Health Record. I think a lot of the press and the media went very quickly to the negative with that. And we didn't have in the back of our pocket, a whole part of really positive use cases about how we can apply that data for personalization of the healthcare models that you might receive. So linking those data sets for your benefit so that you can actually pick when you're at risk of having an adverse event before it happens or a poor health outcome and so on. So, I think we've got to leverage off the back of this COVID to work with consumers and all consumer organizations to really build that social license to use data effectively. Because we need to get at these identified data sets. This is the challenge. Traditionally, we've looked at de-identified data, and that's great for population health planning and that type of stuff, but it's not you can't use it for putting an AI model in or personalizing that care. You've got to keep live identified data sets. So we've got to take our community with us to be able to use that data effectively.
Yeah. And I think, do you think some of that comes from, the language we use or the way we present, the benefits? Because I think, and again, maybe, I'd love to hear your thoughts. Maybe the pandemic is an opportunity because previously not many people understood health or the systems, whereas I think now, because we've been in the spotlight and, everyone's interested, they've taken a little bit more interest in health and, understanding the system, but B, also possibly a little bit more control of their own health and a little bit more understanding of themselves. Is that an opportunity to be able to show the benefits in a way that people will understand without alienating them with, confusing language and
absolutely
things like that?
I totally agree. And I think this is where I would be a strong advocate for programs like the collaborative commissioning work and things like that, where you can work with communities and consumer groups to really identify and demonstrate that benefit to clusters. I think one of the challenges with My Health Record was, there were obviously there were examples of individuals that were benefiting from it, but we couldn't point to a whole cluster of people, say in Western Sydney, who and how My Health Record was improving their cardiovascular disease management or, that type of thing. So absolutely, I think it's a prime opportunity there. And as you mentioned before, I think there's a lot of armchair epidemiologists out there now who suddenly start talking about, what's the chance of ending up in ICU or on a respirator or dying, and, suddenly realizing that there's data sets behind that. And in fact, in this Digital Health CRC, we funded a project to develop new models of prediction around somebody's chance of hospitalization, ICU admission, death, or respirator and death. And we worked a lot with consumers to work with them understand what type of data sets you need to bring together to make those kind of predictions. And you really need to bring global data sets together of people's pathology, their pre-existing conditions, their life circumstances to actually make those predictions. So yeah, it's a great opportunity.
And going back to your point there about armchair epidemiologists, I know it's not your area, but I'd be interested in your thoughts given your experience. What do you think is a good way for us in New South Wales and New South Wales Health, but health in general, to interest people in a career in, say, digital health, or in, a career in health and in data and all those areas? Or is that something where it's a mix of, new emerging workforces and traditional workforces who need to adapt in order to understand digital health better?
Yeah, look, I think the opportunity for people in health and digital is massive, but it's not quite there yet. It's really interesting. So when I talk to young people that are coming into digital health, or whether they have a technology background or a health background, they often get sucked into other industry, banking and finance and others, where there's clear career pathways in there. Whereas in healthcare, I think we're at the beginning of this digital journey. As I mentioned before, high tech's great. If you're building a heart valve, sure, that's great. But in terms of actually being able to use these data sets and actually inform outcomes and change practice, we're just starting down that path. So, I think something we need to be able to do to encourage people to come in is to start to develop these pathways, to start to create these roles. And you're starting to see them emerge. Sometimes people call them the purple people. There's kind of people that sit in the middle, and what those roles are, so that we can encourage our young people to move into them. We can start as a university to create those jobs. I spent some time in Florida in the Moffitt Cancer Center, and they made a board decision about 5 years ago to run as a digital organization because they wanted to move up the rankings of cancer care organizations in the States. And they've got a whole layer of workforce we don't have, which are really kind of clinical informatists that come from either informatics background or from a health background, that sit with the teams and understand their data and work with them. And, you can see that pathway and you meet these young people, and it's a really exciting role for them. So I'm hoping that once we start to create those roles here, that will suddenly start to suck people in, because you have to compete with people that are paying more money outside to go and, modify data apps and things like that. We need to bring them in, because health's obviously a very rewarding career to be able to work on that. But we need the jobs, and then we need to acknowledge you probably need to pay people a little bit more as well when they're coming into those kind of roles as well.
Yeah. And I mean, with the case you mentioned in the US about the virtual, did you call them virtualists? Yeah, navigators. I mean, that's a really interesting role right there, because it's an interface role where, you need someone who understands health, but also is able to use virtual technology in order to interact with patients. And I think you mentioned it was students that they were using.
Well, what they did was they took graduate students. So they took people that had finished their first degree in the US, or they might have done a psychology degree or a science degree. And then they gave them a relatively short but intense training period of about 3 to 4 months to understand what they needed to know about health and the platforms they're going to be using, and then put them out there. So I think that's a new defined role. There's another group I was working with in the United States called HMS, who have access to all the Medicaid data sets in the US, and they're starting to deeply analyze those data sets and reach out to the Medicaid population, which is a lower socioeconomic group, when they identify people with poor outcomes. Or potential for poor outcomes. And I met another whole workforce there, which were the behavioral scientists that were actually working on those data sets and actually influencing the type of information and messaging that went out to consumers about making sure they maintain their screening, or they might need to go and see a GP because they had certain aspects of their care that's coming out there. So I think there's a whole pile of new roles like that are out there.
And that's something that we should probably look to in order to be able to take that next step to Horizon 3, do you think?
Absolutely, because that's the workforce that comes with it. So, I mean, not only do we need to equip our existing workforce to operate in this new environment. And it's not, I don't want to think people think we're going to throw everything out and start again. It's kind of reconceiving what we're doing in ways that make care better for everybody, for the consumer and the practitioner, and then add in these new roles where they have value. But then, as research intensive organizations like University of Sydney, then we've got to demonstrate that it's actually working. I would like to raise another thing, though, that I'm starting to see more of is a major disruption happening, which I think is really important to acknowledge, where there's new providers coming in. So I think we've got to be aware as a health service that it's not necessarily all the players you think that are going to be in there that are going to change the way it happens. So in the US, Best Buy, for instance, which is a kind of a combination of Harvey Norman and JB Hi-Fi in the US, they deliver a lot of tech into people's homes, have just set up a whole Best Buy healthcare service. So they're now employing health professionals. They deliver the technology into your home that can monitor you and so on. And they've got a whole workforce that's suddenly being employed by an organization that understands consumer relationships and interaction. They're built around that whole consumer interface and marketing side. And they're suddenly bringing health in. So I think we've got to be aware that the disruptors are in the house. Google, Microsoft, Amazon, they're all looking at moving into healthcare, and they may come at and take over aspects of the care delivery we assume are going to be owned by our own system forever. And I think that certainly includes community, preventative health, all those types. So I think we've got to be aware that there's going to be some major organizations moving in that will start to deliver aspects of that care.
Yeah, it's an interesting, I mean, my first thought was, oh my gosh, they're going to get my data, my health data, and that's a consideration, I suppose, when you've got, other players in the market, then there's opportunities there for them to commercialize health data. And again, not necessarily that it's a bad disruptor, but it is something we need to be aware of. Do you think? Oh,
absolutely. And look, I'm always marveled. I have an 18-year-old son. I kind of marvel that he'll hand his data over to any large and major corporation that wants it, and then gets nervous about other aspects of the data when it's with government, when in fact, I think it should be the flip there often in terms of the concern level. So absolutely, we have to have the right things in place with that. And I think we know that these corporations, the profit is obviously important to them. There's some very good corporations out there, but we have to be very careful. I guess for government, is keeping up is going to be the challenge with how you regulate that, how you manage that, how we do make sure that we have safeguards around data within there. Because I think we're going to get more and more of this disruption. I actually had a PhD student who a while ago was looking at how healthcare organizations are transforming to digital. And what he was starting to see was that it was very difficult for existing organizations to transfer. It was actually much easier for somebody to come in new to the market and come in. So I think that once you've got that disruption, and as you said, you've got to make sure that we have the road barriers, if you like, in there to make sure that it's done in a safe and effective way.
Yeah.
Because we know that those disruptors can move much faster than health and can employ people and analyze data in ways we can't.
Yeah, absolutely. I think that's always been historically our challenge, is keeping up with private enterprise, because it has less of those restrictions to be able to innovate, and we need to find a way to do that safely. I think you're absolutely right there.
I'll just add to that. I mean, I think that what I'm seeing is a condensation of core health services that we're going to have around the whole. So we know that many outpatient services now are being delivered in the community. So we know we've got to reduce the number of people in hospital and move them out. And as soon as you start to do that more and more, then as soon as people are not in an acute service, I mean, where they absolutely need to have the person and be run by the health system, as soon as we continue to divest healthcare back into the community, that opens the door increasingly to these large corporations that can come in and start to manage that. And we know that Google and Amazon and all setting up, they're moving from health prevention to health care. If you would look at that, you can see there's that kind of shift happening now. So we're definitely going to be working with those organizations moving forward.
It's very interesting, though. It's going to be an interesting world. Thank you so much. It's been absolutely incredible. It was really interesting stuff you're talking about there. And I think it really shows how how much we really need to be prepared. Like, I think there's real big change coming, and I think we really need to step up our game. Absolutely. Well, I don't think we have any more questions. I think we've probably got quite a lot there. Any final thoughts or words for our audience?
Okay, so to wrap up, I think I'd like to emphasize, I think it's an enormously exciting time that's coming forward in digital health. I think there's a whole pile of new roles out there for the young people out there that want to move in, both from an IT perspective and from a health workforce perspective. And I think over the next 5 to 10 years, we'll see dedicated roles emerging, clear pathways for people to move into that system. I think it's going to be really challenging for the health system to manage this disruption and work with the disruptors that are going to be knocking on the door constantly and coming into the room and challenging us. I think we've got to be careful. We've got to maintain that privacy. We can't just hand everything over. We've got to do this in partnership and collaboration. And then I think the key thing for me is it's got to be centered around the consumer. And I think that's going to be what happens over the next 5 to 10 years, is a greater influence on how we deliver consumer-centered care, how that's personalized, how we use the best of the data to understand our trajectories, and then how we wrap technology in a kind of a warm way around our whole journey through life and understand how we can optimize people's care along that whole journey.
Absolutely. I think that's fantastic, Tim. Thank you so much for your time today. Really appreciate it. It's been so interesting to talk to you. I hope you've had a good time as well. And I look forward to working with you again.
That's a pleasure. Thank you.
So that's all we have time for this episode. Thanks for joining me on the show. If you enjoyed the podcast, make sure to like, share, and subscribe on whatever platform you're on right now.